Okay, so welcome everyone, and we're going to go ahead and Rika is going to introduce our wonderful speaker tonight.
I'm going to read.
Over to you.
Sure. Dr. Edwards is an internist who is also board certified in integrative medicine, board certified and fellowship trained in anti-aging and functional medicine, and fellowship trained in integrative cancer therapy. She is also a fellow of the American Institute of Stress. Dr. Edwards is best recognized for her expertise in treating complex integrative medicine issues, male and female hormone imbalance, HPA axis and adrenal dysfunction, and stress-related bodily disorders. In addition to her clinical practice, she has also been actively involved in writing, teaching, speaking, and consulting. She has served as a clinical instructor for the American Academy of Anti-Aging Medicine, the Medical Metabolic Institute, and the George Washington University Integrative Medicine Program. For professional affiliations, do we need to include the American Board of Physician Specialties, the American Board of Integrative Medicine, the American Academy of Anti-Aging and Functional Medicine, my goodness, the American Institute of Stress, the American College of Physicians, Alpha Omega Alpha Honor Society. Dr. Edwards has been selected as one of America's top physicians in internal medicine, integrative medicine, integrative cancer therapy, and is one of the leading integrative medicine physicians in the world by the International Association of Healthcare Professionals. She has also authored numerous articles for mass media outlets and peer-reviewed medical journals. Her self-authored book, Adrenalogic, Outsmarting Stress, has sold thousands of copies worldwide. Very impressive.
Thank you.
And we're going to turn it over to you. Thank you, Rika.
Sure.
Turn it right over to you, Dr. Edwards.
Okay, all right. Well, thank you for inviting me. I appreciate the invitation and the opportunity to teach. I love to teach, and I hope that the information that I share with all of you this evening will be helpful. And it is based largely on clinical experience, but also on scientific research, some of which you may not be aware of. So I'm going to try to give you as much objective information as I possibly can on a topic that's relatively taboo lately, I guess lately meaning the last 10 years or so. It's that evil hormone replacement therapy that nobody talks about anymore because it causes cancer, which we're going to get into that in a little bit more detail. So I know this group is primarily focused on osteoporosis, and so I'm sure there's different degrees of knowledge and different discussions that you've had, but most of you are probably aware that osteoporosis is a significant health problem among women. 1 in every 2 women will experience some osteoporotic fracture in their lifetime at some point. And that actually equals more women than those that are affected by breast and ovarian cancer combined. So that's significant, not only in the number of fractures that women will experience, but also that 1 in every 4 of those people, that women that experience a fracture from osteoporosis, will die within the first 6 to 12 months because of some sort of a complication related to that. So it is a very significant health risk for women. So there are a lot of different risk factors that are associated with osteoporosis. And those things include things like age, genetic background, prescription medications, level of activity, amount of alcohol women drink, whether or not they smoke. But one of the biggest, if not the biggest risk factor, right up there with age, is menopause. And if you look at the research that's been done on osteoporosis, the majority of bone loss that occurs in women starts 1 to 2 years before they enter menopause. And that's the most rapid rate of bone loss in a woman in her lifetime. 1 to 2 years prior to menopause and 3 to 4 years into menopause is when a woman will lose the most amount of bone density. In fact, approximately 10 to 15% of her bone mass will be lost during that 5 to 6 year time span. 1 to 2 years prior to going into menopause, which is defined as no period for 1 year, and then 3 to 4 years thereafter. That's the most rapid rate of decline. Thereafter, there will still be some decline. It just doesn't happen as quickly. But by the age of 70, the average bone loss is about 40%, which is a lot. It's a lot. So, that's why there's such a huge move to try to institute preventative measures as much as possible, because the preventative measures are far more impactful than trying to treat the problem after it's already there. So we're just going to talk a little bit about the different things that influence bone health, in addition to the other risk factors I've mentioned to you. But the menopausal piece of it is extremely important. And so prior to the year 2001, probably from the late 1960s until then, the standard of care for both prevention and treatment of osteoporosis was hormone replacement therapy. Now, the conventional treatment included primarily the use of oral estrogen pills, either the synthetically produced ones, or there's also something called Premarin, which is actually derived from estrogen metabolites from horses, which they get from the horse's urine. And then some combination of that with progestins. And that's very different than what I'm going to be talking about with respect to your body's own hormones. And I'll get to that in just a moment. But for years, that was actually the conventional treatment and preventative measures that was offered to a woman for prevention and treatment of osteoporosis. And it was very effective. But then in the year 2001, there was a very large research trial that came out called the Women's Health Initiative. And it was a study of thousands and thousands of women of different age ranges, different underlying medical conditions. And it was examining the effect of hormone replacement therapy on a variety of different parameters of women's health. There was one group that was estrogen only, and those women had had a hysterectomy, so that was okay. And then there was another arm of the study, which included women that were taking oral estrogen and oral progestin, which is not the same thing as progesterone. And I'll explain that to you in just a moment. And so early in the study, and I guess early meaning about 3 to 5 years into it, they were finding that the women on the combination hormone replacement therapy were experiencing more heart disease and strokes and blood clotting issues. And so actually they stopped the study early that was using the combined therapy. The estrogen only part of that study continued on for a while. And in the end, they came to the erroneous conclusion that hormone replacement therapy was dangerous. It caused heart disease, breast cancer, strokes. Interestingly, they claimed it reduced the risk of a woman developing colon cancer. But otherwise, pretty much all women need to stop their hormones ASAP. And that's pretty much what happened. So all of a sudden, women were frantically coming off their hormones, and there really weren't any decent alternatives at that time for prevention and treatment. And so the pharmaceutical industry got busy on trying to come up with therapeutic alternatives to hormone replacement therapy. Now, I won't spend a lot of time discussing this, but several years later, actually as early as 2003, so that was about 2 years after the research results were released, it came out subsequently in that research paper and multiple ones thereafter, over 300 of them actually, that many of the results of that particular study were flawed and were not accurate and were not a basis for coming to the conclusion that women should not use hormone replacement. In fact, there's been so much research done subsequent to that study to argue the complete opposite point. But for some reason, it's interesting that nobody pays attention to that subsequent research, even though there's quite a bit of it and quite a bit of it which shows beneficial health effects. But again, depending on how you give it. So we're going to talk about the nuances and the specifics when it comes to properly dosed and properly monitored hormone replacement therapy. So anyway, after that, they came up with different classes of drugs, which they continue to develop even until now. But it's been unfortunate because with respect to osteoporosis, hormone replacement therapy is still considered to be one of the standards of care, just as effective, if not more effective, and if properly monitored and dosed without side effects compared to the other medications that are now available to treat osteoporosis. Now, again, I'm not saying that hormone replacement is the only way to deal with osteoporosis, because That's not necessarily the case. Age plays a role, calcium and vitamin D metabolism play a role, gut health plays a role. There are other factors that will affect the age at which a woman develops bone loss and the extent to which she experiences bone loss, but menopause ranks right up there as far as the sort of the impetus to push a woman in that direction. So I guess one of the things that that Shelley had asked me to speak about and that I wanted to also discuss was some of the intricacies of hormone replacement therapy, and to try to dispel any of the misconceptions or myths that may be out there that have been propagated by the conventional medical community and the media, as far as the safety of using hormones if they're being properly dosed and monitored. So the timing is important. If you're considering hormone replacement therapy, obviously, the sooner that is initiated when you're in menopause, the better, because it is considered to be preventative. That's not to say that there isn't benefit starting it later, but because the rate of bone loss happens the most dramatically in the time frame that I already explained, it's the most impactful if you start hormone replacement therapy prior to that, or at least during that time frame. It's also been shown that hormone replacement therapy is as effective, if not more effective, at reducing every fracture, hip fractures, spinal fractures, and hip bone fractures, as the prescription medications. The thing about hormone replacement, though, is if you're going to be using it for osteoporosis prevention and treatment, it needs to be continued lifelong, because the minute you stop it, then the beneficial effects of the hormones go away. They're not stored in the bone. There's no like long lasting impact, which is really the case if you're using hormone replacement for any other medical problem or medical challenge that menopausal women experience. And just to that point, the majority of illnesses that affect women affect them after they've gone into menopause. I always tell my patients that if hormones cause cancer, we would all be getting cancer when we're 25, because that's when our hormone levels are at their highest. So the whole hormone cancer connection is far, far more complicated than most people understand it to be. And, you know, whether and to what extent we develop cancer and what types of cancers is frankly influenced far less by our genetic makeup and far more by environmental influences, which include things like lifestyle, smoking, diet, alcohol consumption, sleep, stress, gut health, whether or not you're diabetic. I mean, there are lots of other hormones and lifestyle environmental things that are impactful when it comes to our genes, because our genes, actually our genetic makeup is predetermined and not changing. But there are a number of factors, some of which I've just mentioned, that are called epigenetic phenomenon, where you can have a certain DNA, but how your cells will express that DNA will be affected by the factors I just mentioned. So that's why some patients may not have a family history of osteoporosis at all, but they can develop osteoporosis because of the epigenetic phenomenon, like smoking or drinking or stress or sleep or whatever. So there's lots of other things that will influence your health. So quite frankly, the true statistic for genetically acquired diseases is less than 5%. The rest of it has nothing to do with your genetic makeup. And on the flip side, there are a lot of patients that have a genetic predisposition to developing a disease, including osteoporosis, that may never develop that disease because the environment in which they place their DNA and genetic material is favorable so that those abnormal genes aren't expressed. So hopefully that makes sense. I will give you all a chance to ask me questions, hopefully, as I'm getting close to being done. So anyway, I've been practicing for almost 25 years, and I have been a huge advocate of properly dosed and monitored hormone replacement therapy because in my experience, I have seen it do nothing but amazing things with respect to disease reversal and disease prevention. So just as a quick aside, even though it's not specifically related to osteoporosis, it is directly related to women's health. 2/3 of all Alzheimer's patients are postmenopausal women. Women that lack estrogen, their rate of heart disease, risk of heart disease goes up 50%. So if you look at all of the diseases that afflict women in menopause, including osteoporosis, that is significant compared to the risk factor, or the risk, I should say, of developing breast cancer, which quite honestly has everything to do with not whether or not you're taking hormones, but how your body is processing even your own hormones. So most women that get breast cancer don't even use hormone replacement therapy. So that's where it gets a little bit more complicated. And I know this is not a discussion about breast cancer, but I know that there's a big stigma against using hormone replacement therapy because of the fear of breast cancer in particular, but other health issues as well. So now, when you're talking about hormones, and again, I'm a big advocate for hormone replacement, but I also know how to do that. There's an important distinction between the types of hormones that are given, the forms in which they're given, the doses in which they're given, and a woman's general health in the context of when she's given the hormones and how long they're continued. So what I find interesting is birth control pills are very, very popular. I will argue that childbirth and parenthood are arguably more stressful and impactful on your health than hormones are, but that's my own opinion. But birth control pills actually are pretty dangerous and are basically riddled with side effects that surmount even that of traditionally prescribed hormone replacement therapy, but nobody has a problem, prescribing birth control pills. So, and they actually believe that part of the reason that there's been such a rise in breast cancer is because of the significant use of birth control. So when you're talking about osteoporosis, from my perspective, it's a key part of the treatment of osteoporosis, prevention and treatment. And it's been shown that even if you do other prescription drugs, even if you do the proper amount of calcium and vitamin D, the addition of hormone replacement actually substantially increases bone mineral density, as opposed to using all of those modalities without hormone replacement therapy. So that's another, I guess, argument in favor of considering hormone replacement therapy in the treatment and prevention of osteoporosis. When you're considering hormone replacement, the problem with how we're trained in conventional medicine is hormones are hormones. There's no distinction or difference between them. And they're typically always given orally. And more recently, basically the recommendation was to keep them to the absolute minimum. Don't give them at all unless absolutely necessary. And if you're going to have to give them, keep it to less than 2 to 5 years maximum, and then stop them. And again, all of those teachings really were based on faulty scientific information. So that's why one of the things I had sent Shelley, and I'm sure she'll send it to all of you, is just I could literally have put thousands of papers, but I sent her just a listing of some of the more, I think, layperson friendly, where you can read them and understand them, research papers talking about the safety of bioidentical hormone replacement. So let's talk just a little bit about what that means. Conventional medical therapy, okay, if you were to take an estrogen pill, unless it's Premarin, which comes from horse urine, but estrogen pills and estrogen patches and estrogen pellets, those are technically bioidentical forms of estrogen. And what that means is, if you were to look at the biochemical structure of those types of estrogen and compare them to your body's own estrogen, they would look identical. That's basically what that means. So then when it comes to progesterone, which is your body's natural anti-estrogen, just as important for building bone. Progesterone helps to build bone. Estrogen helps to prevent bone breakdown. Testosterone helps to do both. So when you're looking at hormone replacement, you really need to be looking at replacing all of the hormones, not just estrogen, not just progesterone, but at the very least, estrogen, progesterone, and testosterone. There are 2 other hormones, DHEA and cortisol. Those 2 hormones are made by the adrenal glands. DHEA is considered to be a sex hormone simply because once a woman goes into menopause, the body uses DHEA to actually make estrogen and testosterone. And it's for that reason, actually, that there's scientific evidence to show that replacing even DHEA is helpful for bone mass and bone health. But the way that you give the hormones makes a difference. And the type of hormone that you give makes a difference. So when it comes to estrogen, if you look at the research that's been done, the majority of the harmful side effects that come from hormones is when they're being given as a pill. And that's because, especially in the form of estrogen and testosterone, because when those pills are swallowed, the process through which they have to go to be metabolized creates byproducts that are harmful. So the estrogen itself isn't dangerous, but the metabolites of the estrogen that occur once you swallow the pill are dangerous and can cause everything from heart attacks and strokes to gallbladder disease and blood clots and, yes, breast cancer. But that is dependent on the form in which you give it. Progesterone, none of the commercially available forms of progestins are actually progesterone. So if you think about it this way, progestin is chemically, part of it is similar to your own progesterone, but part of it looks nothing like our own progesterone. And so the way I explain it to my patients is that the progestins that are typically prescribed, like Prem-Pro or Provera, or what's given in birth control pills, they can park in the same garage as the body's own natural progesterone, but they do everything opposite to what natural progesterone does. So natural progesterone is your natural estrogen balancing hormone. It's an antidepressant. It's a bone building hormone. It helps prevent breast cancer. It helps with brain health. It has a whole host of different roles in the body. But when they give a woman progestin, even though they use these terms interchangeably and they will tell you that it's progesterone, it's not. And it doesn't do remotely the same thing. The only thing it does is protect the uterus from the effects of estrogen. But in every other respect, progestins are anti-progesterone. And that's why so many women have so many adverse side effects. And if you look at the research on hormone replacement therapy, the majority of the bad research, the bad outcomes have happened in women that are taking estrogen with progestin, not progesterone. Some of the research papers I sent to Shelley, the links, actually talk about how the use of transdermal estrogen, either in patch or cream form, and oral bioidentical progesterone actually help prevent breast cancer and have much with respect to beneficial effects on women's health without the adverse side effects of the other forms of hormone replacement therapy that we've talked about. So not all hormone replacement therapy is created equal. The way you give it matters. Oral estrogen is never safe, even if it's bioidentical. Oral testosterone is never safe, even if it's bioidentical. Progesterone is not the same thing as progestin. And it is safe. You can give progesterone orally. I do that very often. And then DHEA, again, I'm talking about it in the context of a sex hormone, even though it's really an adrenal gland stress hormone, but kind of as a segue from bioidentical hormones, because I don't want to just focus on that. One of the other things I wanted to spend just a few minutes discussing was also the impact of other hormones on osteoporosis and some of the other things that need to be considered if you have osteoporosis, aside from just simple hormone replacement therapy. So I'm trying to give you a basic overview with bioidentical hormone replacement therapy being part of that. That in and of itself could probably be a 3 or 4 hour long lecture, but I just want you to understand that it should be part of the consideration for therapy, for prevention and treatment of osteoporosis, not just for the osteoporosis, but because of the beneficial health effects it has on heart and bone and brain and mood and weight and all the other things that estrogen and progesterone and testosterone are helpful for before we go into menopause. So that's something that you need to consider, but you have to be very careful that you work with someone who knows what they're doing, monitors you frequently, you do your annual mammograms, et cetera. And I've given you a few little jewels as far as how they should be administered. I prefer to do the bioidentical hormones through compounding pharmacies because I can select exactly what dose I want in my patients and how I want them to have it. Whereas I like estrogen patches are fine, but you get to pick from 4 doses and that's all you get. So, every patient's different. but there is a safe way to do it. I've been doing it almost 25 years. I've never had a patient get cancer, but the doctor needs to understand the way that the hormones work. The female hormones affect all the other hormones, and all the other hormones affect female hormones. So actually, I'm going to pose this as a quiz question, and then when we do a question answer, I'm going to see if anybody gets the answer. I'm going to pose to you the question, which hormone is naturally produced by the body that actually has been associated with causing cancer more than any other hormone? So I'm not going to answer that for you yet. I want you to ponder that, and I'll see if anybody has the answer for me. No fair Googling, because you have to be watching me while I'm talking. So you can't Google the answer, that's cheating. So anyway, there's a couple of other hormones I wanted to mention, not only because they're important for osteoporosis, but also they're important in the context of overall hormone balance. So it would be a big red flag if you were to go and see a physician who wants to start you on hormones without getting a big picture of what all of your hormones look like. Things that include your thyroid hormone and your cortisol and your DHEA and your insulin and your growth hormone, because the hormones are like one great big family Christmas dinner. And, you know, unless you want to put away the sharp objects and make sure everybody gets along okay, you really have to understand the relationships between all of these hormones and understand, okay, well, if I have a patient and I'm going to give her estrogen therapy, what's that going to do to her thyroid? Okay, so it's all about balance, and the doctors really need to understand how these hormones affect each other. It's not as simple as, oh, you have osteoporosis, let me just give you some estrogen pills or some even progesterone pills or cream or whatever. But what's happening with the thyroid? You know, hypothyroidism and hyperthyroidism can cause increased bone loss. Cortisol, that is a huge, huge, huge issue. No doctors ever check that. But if you have stressors of any kind, and I'm not talking about just psychological stress, your body does not differentiate between types of stress. So stress from not sleeping, stress from having an argument with your teenager, stress from taking prescription drugs, stress from a lifelong, you know, battle with one or more chronic diseases. The body's stress response system is the same. It doesn't change, and it doesn't, the reaction isn't different based on the stressor. Moreover, women in particular, menopausal women especially, are more susceptible to having abnormal cortisol patterns for a variety of different reasons. And cortisol is the most damaging hormone when it comes to things like bone loss, brain loss, heart health, pretty much everything. Because cortisol is designed to keep you alive, not to keep you healthy. And it's meant to be there in the short term so that if you are faced with a stressor, you can either fight off the stressor or flee the stressor, and then everything is supposed to go back to normal and your cortisol levels are supposed to come back to normal. That's not how life in our world works this, you know, these day and age. So I rarely work with patients that have optimal cortisol. And if your cortisol levels are too high or too low, that also has a huge impact on your bone health. Huge. In fact, some of my patients that are even doing hormone replacement therapy, if they have conditions that are creating problems with their cortisol, they will still lose bone mass. So that's another important hormone that needs to be examined. Growth hormone. There is a condition called adult growth hormone deficiency. It's more common in women than in men. And it can also lead to osteoporosis. It's more common than most people think it is, but it's something that most physicians don't check you for. And it's important to check for it, because you can use hormones, you can take 5,000 milligrams of calcium a day. But if you have a problem with your brain producing optimal amounts of growth hormone, you're going to lose bone mass. So that's another really important hormone that needs to be, looked at and make sure that it's where it needs to be. Now, obviously, there will be an age-related decline in the levels of hormones. And that doesn't always mean that, like in the case of growth hormone, that you have to replace the growth hormone. But I guess my point now is that there are factors that should be considered and should be looked into in women that have osteoporosis, rather than simply giving them calcium and vitamin D, or even Fosamax or one of those types of drugs, or even just hormones. especially if a woman has bone loss that's disproportionate to what it should be for her age. Okay. I'm sure most of you are familiar with DEXA scans, bone density scans. Can you nod yes? Are you familiar with T-scores? So T-scores are basically the scores that compare your bones to that of a average 25 to 30-year-old woman. And then there's a Z-score, which compares your bones to the bone health of a woman your age. And if all other things are equal, then when you have a bone density scan, your T-score might be off, but your Z-score should be 0 if the only reason that you have osteoporosis is your age, okay? If your Z-score is not 0, then that is an indication that you have bone loss disproportionate to a woman your age, and there are other things that need to be considered as secondary causes for bone loss. Does that make sense to everyone? Okay. So I'm not a plug and play girl. I don't want to plug in a drug or a supplement or a hormone just because I see bone loss, unless I'm doing my due diligence to make sure that there's nothing else that's causing bone loss. One medical condition, actually 2 medical conditions in particular, that I want to point out because they're much, much more common in menopausal women, and they're very impactful for osteoporosis, are sleep apnea and diabetes. And those 2 conditions, the risk of a woman acquiring those 2 conditions go up significantly when they go into menopause. With respect to sleep apnea, a woman's risk of sleep apnea, developing sleep apnea, goes up 8 to 10 times after she goes into menopause, because your hormones actually have a huge role in affecting your breathing. And there's a variety of reasons why it happens. I don't really have time to get into it, but menopausal women, because they gain weight, because they lose their hormones, et cetera, have a much higher incidence of developing sleep apnea. One of the research papers I sent Shelley to send to you guys is the association between sleep apnea and osteoporosis. Huge. And it's because of the imbalances in cortisol and insulin and growth hormone, primarily, that are created when a woman has sleep apnea. Okay, so the other condition is diabetes. And women that are postmenopausal have a much higher incidence of developing type 2 diabetes, because without estrogen, your insulin is not going to work very well. And women gain weight, which is another predisposing factor. But women with diabetes also have an increased risk of developing osteoporosis. So when I'm talking about hormones and evaluating hormones and hormone replacement, it goes far beyond just estrogen and progesterone. You know, there are all these other hormones that there are very good ways to evaluate and ways to correct, but they have to actually be looked at. Otherwise, you're not going to know. So the other hormone that's really impactful and important is parathyroid hormone. That controls calcium and vitamin D regulation in the body. So, you know, in a woman who's got a parathyroid hormone problem, that can also lead to osteoporosis. So, and then there are some other more, I'm not going to say less common, but other things that you might want to consider aside from hormones: celiac disease, autoimmune diseases, gut. In fact, there's emerging research talking about the importance of probiotics and their role in the prevention of osteoporosis. So the story is much greater than, and fish oil is another one. So it's a lot more than just calcium and vitamin D, although those 2 things are very helpful. And even though I'm trying to give you some information about even considering to add bioidentical hormone replacement, I also want to keep the vision and the view broad so that you understand that there are other hormones and other medical conditions, prescription drugs, other things that can influence the rate of bone loss and the extent of bone loss, and whether or not the treatment that you're using is actually going to be effective or not. Not mentioning what you eat, how you exercise, do you smoke, do you drink, how stressed are you? Obviously, all of those things are just another layer of complexity on our lovely, complicated human bodies that impact everything I just discussed. So I could literally talk for days and I would probably bore you all to death. So I wanted to make sure and at least try to cover what I felt were some, major talking points And then obviously give you guys enough time to ask me questions that you might have about anything I've discussed, or maybe something I haven't discussed that I hopefully will know the answers to. So I'm not sure, Shelley, if you think this is the right time to do that, but.
Yes, it would be great.
Okay.
Boy, that was wonderful. Thank you very much, Dr. Edwards. That was a lot of information. I think I'm going to watch it again. Glad we recorded it. I know there's a lot of you that have may have questions, and I want you to unmute now, if you would, just so you can offer a question or perspective or appreciation or anything you would like. Yeah, Rika, go ahead.
So if I can ask a couple of questions, I found it really interesting what you had to say. So you're saying, I'm 72 years old. I'm on a medication right now for osteoporosis, and I could benefit potentially. I mean, you don't know me, but I could benefit from hormone replacement therapy.
So you're going to get a mixed bag of answers on that, depending on the physician. I absolutely positively would say yes to that. And there's research to support my opinion, but there's other research to say that you might not, again, since the rapid decline in bone mass has already happened, that you might not derive as much benefit from it, starting it later. But again, I am looking at the whole person and all of the different health factors and issues that women have, not just osteoporosis. So I'm looking at things like brain function and heart function and, stamina and mood and weight and diabetes. And so from my perspective, I would start any woman at any age on hormone replacement therapy. I've done it, and I've seen nothing but beneficial things come from it. Whether and to what extent it's going to help the osteoporosis, it will certainly help prevent additional bone loss. It may not help you regain what you lost, 20 years ago or however long ago you went into menopause, but it certainly isn't going to hurt, and it may actually even be helpful. At least that's what the research would indicate.
And just clearly, this must be somewhat of a controversial issue. Why is it that my endocrinologist, and many don't, he's a man.
Well, to be fair, I have had patients who've seen both genders, and unfortunately, that does not seem to make a difference as far as the level of open-mindedness when it comes to hormones. And again, all I can attribute it to is that big study that came out in 2001, because before that, all women took hormones. Literally every patient I saw was on hormone replacement therapy and doing really well for the most part. So after that study came out and doctors got freaked out and patients got freaked out and everybody just stopped their hormones, I really think ever since then, again, even though there's been hundreds and hundreds of studies after that one showing that what they concluded was actually wrong. Because when you're looking at a study, this is so important, because the media will flash headlines. Okay, this research study showed X, Y, or Z. You can't just take that at face value. Okay, who was the study population? Were they already at increased risk for developing heart disease? Were they, diabetic people with high cholesterol and high blood pressure, and you gave them hormones? Okay, well, that's not fair, because they were already predisposed. How old was the group? Where did they live? What other occupational or environmental factors were a role? So when you're looking at the research end result of any research, you really have to look at who they studied and how they did the study to really evaluate whether or not it was even valid. So after they go back and they look at that from that big, huge study that they did years and years ago, for some reason, doctors just refuse to revisit that. And it's a travesty, because I take care of so many women who their quality of life is just terrible, not just from symptom perspectives. Women usually hot flashes and night sweats will eventually go away, but you never go through menopause. You're there. When you're there, you're there. And on average now, we live a third of our lives in menopause. And that's when you can look forward to things like irreversible weight gain. It's just never going to come off. And brain fog and, insulin resistance and all of these other things that I'm not saying happen in 100% of women, but they're substantially more likely to happen in a woman when they're in menopause. And so I guess I'm really passionate about it, because there's so many women out there that are having all of these issues and symptoms, and doctors refuse to revisit the hormone replacement story and to get the bigger picture on all of the things that have happened since that study and sort of re-examine and rethink the way that they think about hormones. My personal opinion also is that hormones are really complicated, and it's really, really, really difficult to understand them. And most endocrinologists don't even understand the complexity. I mean, I've given lectures where I've had Harvard trained endocrinologists that are like, how do you know all of this stuff? And I'm thinking, why don't you? You know, so it's not easy, and it's time consuming, and it requires a lot of time with the patient, and it requires an understanding of the complexity of hormone relationships. And it's complex. I mean, it's probably one of the most complicated systems in the body. And I think that may be part of it also. It's just easier to draw a lab and say, oh, you're in the normal reference range, or, oh, you're not, or hormones cause cancer. And, you know, if you only get 5 to 10 minutes with a patient, you really don't have the time to go deeper than that. I kind of got sick of practicing that way, so I decided not to do it that way anymore. But a lot of doctors, I guess, aren't there for whatever reason. So I can't answer the reason. That's my hypotheses, my theories as to why they don't, based on my experiences.
And Lola, did you want to say something? Wait a minute. I think you're muted. Wait a second.
If you're done, Rika, then okay, thanks. So thanks, Dr. Edwards. That was really interesting. So, you know, just what you were saying now was a good segue to my question, which is how I'm based in Manhattan in New York, and how do I actually find that qualitative physician, whether that person is an endocrinologist or not, because I'm already on my second person because I'm trying to find a person who's the right fit for me. And to your point, you know, it's everything you said. Nobody has time, seemingly not the interest. You know, it's kind of like a business medicine as opposed to what it should be. So, I mean, and then I was given the opportunity only after speaking up and not knowing now with what you've shared about, you know, really looking at this so holistically and much more cohesively than perhaps most people would or do with the HRT. But I was, you know, just given, okay, take this amount of estrogen as a patch, take this progesterone pill, which I've had difficulty swallowing, and I literally kind of found myself in a choking moment, and I couldn't get past that, and I've just like stopped cold. I mean, I shared that with the doctor, but the point is, you know, listening to what you're saying, I mean, the fact that this current physician, what is it called, a CTX test, blood test, you know, I said she had me have one recently, which for everyone else, it's if I'm saying it correctly, it's to get a gauge of the extent of the rate of one's bone loss in points. It comes out, you know, X number of points.
It's a urinary test.
Oh no, this was the blood
test.
The blood test.
Okay, yeah. So those are, yeah, just so that if people don't know what those are, there's a blood test, a CTX and an NTX that can be done in the blood and the urine, and those are markers of bone turnover. So they're a better way to gauge what's happening now as opposed to a bone density scan, which, you know, 5 years from now might change. So.
And so the thing is that, just to give you a sense of, you know, attention to detail, I had already been on the estrogen only for an initial month and had a follow-up visit before the progesterone was introduced. And that's when
I'm sorry to interrupt you, but do you have your uterus?
Yes, I do.
Oh, wow. Wow.
So, and the point is that I had this blood test, but then after having had it, I said to the physician, but we don't have a baseline. Oh, you didn't have that done already? I mean, so I'm just like, I'm in a very bad place right now, and going back to where I started, just to get back on track for everybody and for you. How do I find somebody I can work with in Manhattan? I mean, I mean, and you know, I'm fine with remote, but I mean, the person doesn't have to be local, I suppose, at this point. But there's obviously some value to being able to have the flexibility to do both in person, if feasible, and you know, and virtual.
Well, first of all, I have to say this before anything: don't ever, ever, ever use estrogen without progesterone, because you have a uterus and you will get uterine cancer. Don't ever do that. So
well, that was the other thing that struck me, is why did this person
they should have
even
never done that.
permit me to go for a month without it? She only, you know, brought in the progesterone a month later.
Yeah, that's
and
bad.
yeah. And
Okay.
again, like I said, I'm at an impasse now anyway, because I
Yeah.
literally could not swallow that pill.
Well, I'm not sure what she gave you, but also there are different ways you can dose progesterone. You can do it as a liquid. You can do it as a lozenge that you dissolve under your tongue. You know, there's all kinds of different ways to do it. Cream.
Do you
So-
know that I asked that question about, I'm not kidding. I must have asked like over and over and over. I kept calling the office and I kept getting told this is the only way it comes.
Well, then that's probably a doctor who's not very familiar, or not familiar at all, actually, with bioidentical hormone replacement. They're probably just going the conventional route, in which case that's would be their answer, because that's all that they have knowledge-wise. That's all that they have available in their reservoir. As far as trying to find someone, that is always the most difficult question for me to answer, because I don't ever know what to tell people, because there are, you know, physicians, nurse practitioners, physician's assistants, chiropractors, naturopaths, and a whole host of different types of physicians, from emergency room doctors to ophthalmologists, believe it or not, that are out there, you know, professing to know how to do hormones or functional medicine or integrative medicine. And the problem is that there are training programs out there, but none of them are recognized as like the national standard. And I know, because I've taken part in some of the training, and I've done a lot of teaching for a lot of the organizations, and it's just sort of like the Wild West. And so people are kind of out there sort of doing whatever they do. They'll go take a weekend course or maybe something a little longer, and then all of a sudden they know how to prescribe hormones. Gynecologists, on the other hand, really, they just sort of do what experience you just described, actually, is what most gynecologists will do. And they are not able to look at the big picture, because they really focus mainly on sex hormones. They don't really know a lot about thyroid hormone and cortisol and DHEA. Endocrinologists are supposed to know about that stuff, but then usually they're deficient in the estrogen, progesterone, testosterone part of it. So I have found, unfortunately, that it really doesn't matter the level of training. Well, the level of training matters, but as far as whether they're conventional doctors or integrative medicine doctors, it's really a matter of level of experience, patient outcomes. And, you know, I have a Facebook group where I do a lot of teaching, and I tell patients things that they should look for. I think I even have a video there on what to look for if you're looking for someone to try to work with in this way. And I'll teach them, like, for instance, I just told you, if you're working with a doctor that gives you unopposed estrogen, you need to fire them on the spot and find somebody else. Or like I told you guys earlier, taking estrogen pills are dangerous. Don't ever do it. So I try to give patients enough education so that as they're going out looking for people, they'll sort of know what the red flags are, so they can, you know, go in. And sometimes they have to interview multiple different people before they find someone they're comfortable working with. But that's really tough. And short of like Googling and getting reviews, you know, I really, or talking to other people that you're aware of that might be seeing someone, it's really difficult to find someone who's proficient and kind of knows what they're doing. So that's why a lot of women actually end up working with people remotely, because sometimes those are the only people you can find that do know what they're doing. And, you know, with like in my situation, I have my patients, you know, continue with their regular doctors in case any kind of physical ailment comes up or they get a cold or whatever. But you know, my whole practice is remote, and it works perfectly well, because the complicated, difficult stuff that patients need assistance with, they can get that from me, and then they can go do their physicals and all the other stuff with their other doctors. So you can check The American Academy of Anti-Aging Medicine, they have a physician directory that gives you a list of different doctors. Another thing to do would be to call a local compounding pharmacy. Compounding pharmacies tend to be familiar with doctors that are a little bit more versed in hormone replacement therapy, bioidentical hormones, and they may be able to direct you to someone who's good too. Because pharmacists will know if a doctor knows what they're doing or when they don't, because pharmacists know what doses are the right doses and how it's safe to give it and how it's not. So usually they're pretty forthcoming when they'll tell you who to see. And usually they won't tell you who not to see, but they'll usually tell you who to see as far as trying to recommend someone. So anyway.
Now,
Thank you. Thank you.
Lola, that was excellent. And same with your question, Rika. I really appreciate hearing your questions. I have a comment, and I don't know if this is a question, but I'll just blurt it out anyway. I took hormone replacement therapy for probably 10 years when I was in my late 30s to my late 40s. And it was not for menopause. It was because I had very bad cramps, menstrual cramps. And there was a doctor at that time that gave that as a suggestion, if you will, to his patients as a cure. I don't know that it cured me. I don't think it did, but it did lessen it a little bit. And my question from this is, at the time I took a combination, thank God, of estrogen with progesterone and testosterone all in one pill. And then he would somehow do it in his own lab and put the thing together. And he was a regular endocrinologist out of Worcester, Mass, by the way. At the time I took it. So I'm just wondering, do you think there's any bad side effect, if you will, for having taken it at that juncture of my life, being so much younger?
I'm going to say no, but the way you were getting it was dangerous because you're not supposed to take estrogen or testosterone in your mouth. That's always going to be a bad no-no. But no, the hormone replacement, it's replacement in menopause, but you can use it in women that are much younger to address things like PMS, endometriosis, polycystic ovarian syndrome, excessive uterine bleeding. So in those situations, there's an indication for the use of hormone rebalancing is probably a better way to put it when you're using it that way. But none of those women ever need estrogen. Unless you are in menopause, late perimenopause or menopause, you do not need estrogen, ever. Your body's making plenty of it. Heavy bleeding, frequent bleeding, PMS, all that stuff, fibrocystic breasts, uterine fibroids, all that stuff is all estrogen dominance. You probably did not need the estrogen.
Mm-hmm.
So, but there is value in using primarily progesterone, properly balanced, properly monitored progesterone in a lot of the other conditions I just mentioned. But again, as a big picture with other hormones, but never estrogen. I never need to use estrogen in women that are still having their periods, ever.
And if it were testosterone, it would also be a cream? Is that what I'm understanding?
Well, testosterone replacement is misused and abused a lot. A lot of women, so testosterone is made, half of it's made in the adrenal glands, the other half of it's made in the ovaries. So yes, a menopausal woman may have low testosterone because her ovaries aren't really, you still make hormones from your ovaries when you're in menopause, it's just a fraction of what you were normally making prior to menopause. But I've had menopausal women that have normal testosterone or sometimes even high testosterone levels for a variety of different reasons, because I'm not going to try to complicate this, but it's going to complicate this because hormones can convert into each other. And so our bodies actually make estrogen from the conversion of DHEA and testosterone. So in some women, and this is where I find women have some trouble, if you've got disproportionately low testosterone and the doctor just gives you testosterone, what if your testosterone was partially low because your body was turning it into estrogen? And then you give someone testosterone and it just keeps turning it into more estrogen. So that's where I'm saying the complications with hormone anything, it's very sophisticated, very complicated, and you have to understand those relationships, because otherwise you can give a woman testosterone replacement. And I have seen this in patients, and they'll come to me, they've had to have hysterectomies because their uterine bleeding got so bad because all the testosterone they were getting in the pellet they got or whatever was turning into estrogen, and they just couldn't stop bleeding, for instance. So, but testosterone by mouth is not safe. You can do it as a pellet if somebody knows what they're doing and doesn't give you too much. And you can do it as a cream, but never as a pill. So
Thank you.
Anyway, I hope this was helpful.
Yeah, quite helpful.
I always, when I give talks like this, it's like trying to explain world history in an hour. And it's like people's heads start to spin and they're like, but wait, but what about this? But what about this? Yeah. So it's like people come away thinking, oh, we're going to learn all this great stuff, which they do. But then they're also like, crap, now I have all these other questions I don't know what to do with. So I'm sorry about that. I'm sorry about that. But
I have a quick question. I'm new to this. I just got my diagnosis 3 weeks ago, and I haven't seen my specialist yet, but I'm like kind of, I don't know what to expect from my endocrinologist. What question should I ask her, or what kind of test?
Well, I mean, I think would review the video that I just did. I mean, I mentioned a lot of the different things that you need to consider when it comes to osteoporosis. You know, how bad was the bone loss? Are you in menopause? If so, how far into menopause are you? What other prescription drugs do you take? Do you drink? Do you smoke? You know, all those things that we reviewed.
My only risk factor is being thin, and I'm a postmenopausal woman. I'm 57 years old. Other than that, I don't have a family history.
Well, yeah, but most people don't. Most people don't. So there's all kinds of other things that go along with that risk. But as I mentioned before, there's other hormones that need to be looked at.
Yes.
You know, there are certain supplements, which they may or may not know about, that have been shown to be helpful as, you know, treatment, or at least part of the treatment of osteoporosis. You know, ask about the relevance of hormone replacement, and is that something that they would recommend, as opposed to just a drug? Maybe they don't think you need a drug at all. I really don't know. I don't know enough about your history to really tell you what specific questions to ask, but hopefully the information I've provided in this lecture will give you some general places to start.
Is there a way we can email you with some questions? Or
probably not.
Oh, okay.
You know, I'll be more than happy to think about doing another lecture, but I'm just so inundated with other activities and responsibilities right now. I wouldn't want to say yes and then not have the time to answer you.
All right, that's fine. So hormonal therapy is for lifelong?
Ideally, yes. Yes, it would be indefinite, because the minute you stop the hormones, any benefit you would be deriving from them would be gone, because your ovaries aren't going to make ample amounts of those hormones anymore. So yes. And I've had patients, well, gosh, going on 27 years of doing hormone replacement that are doing beautifully, but I monitor them closely, and I, you know, do all the things I just told you I do, and they all do really, really well. So anyway, Shelley, thank you so much for having me.
I want to thank you, Dr. Edwards.
No problem.
Wonderful.
Oh, good. Good.
Lots of information, and I think that if everyone just took a minute and listened to it again, and took more notes on things you might have missed, you will have a lot of information to.
Well, and another thing I think it's important when you go and start questioning your doctors, which usually they don't like or appreciate, but that's okay. It's not a popularity contest. It's your body, and you need to know, and they need to know. But, you know, that's one of the reasons I sent you that list of research papers and scientific, because doctors are always about evidence-based medicine. Well, there's evidence to support every single thing I told you on this lecture. So if you want to have a discussion about hormones and they say hormones cause cancer, they're dangerous, you know, take them in the, you know, the little list of links I'd said, you know, here, can you please look at these and tell me if you really still think that after you look at the research, what the research shows. So, you know, but again, it's time consuming. Doctors don't like to be questioned, and they would have to have the extra time and willingness to do that. So anyway, all right, I'll be quiet now.
Thank you. We appreciate
You're very welcome.
Hearing. We'd love to have you back sometime. And,
okay.
You know, I know everybody, I'm just speaking on behalf of everyone, but really appreciate your time.
Absolutely. My pleasure. Okay. Well, I have to go take my hormones now because I'm having hot flashes. Seriously, hot flashes. Woo. So, all right. On that note, thank you again. I hope you all have a wonderful evening.
you.
Mhm.
Thank you. Thank you so much.
And, I just want to say to everyone that I will send the replay out. And so